Okay, welcome. This is our perimenopausal informational webinar. Thank you all for being here. We may have a few more people joining after we get started, but I'll turn this over to our presenter, our nurse practitioner, Carolyn Tucker, who will get us started. Thank you. And feel free during the presentation to put your questions in the chat box. And as we get to the end, Carolyn will leave time to answer your questions. Thank you.
Everyone, I'll be hosting your Understanding Perimenopausal slideshow today. And just a quick history about myself. I'm a mother of 5 and a grandmother of 22. So I can honestly say, been through this. I have a nurse practitioner certificate from 1996. I'm board certified in women's health. I've been trained in naprotechnology since 2004 and practicing it ever since. I'm a graduate of medical school in 2019. I've worked in disaster and emergency care as well. But today we're going to be talking about perimenopause. And so to begin our talk, we really do have to understand the basis of our reproductive system. So we're going to go really quick highlights through understanding reproduction. All right. And to begin with, we have to begin with puberty. When a woman begins to go through puberty, hormones from the pituitary gland secreted signals the ovaries to start functioning and forming eggs. The eggs are inside small follicles. These are little cystic structures, and they look exactly like little cysts. And the hormone that comes from the pituitary is called FSH, or follicle stimulating hormone. Its job is obviously to stimulate follicles to grow an egg. Once the egg is matured, the follicle in which it's developing is now producing the maximum amount of estrogen it will for the entire month. And once this happens, within 24 hours, the egg is released. You'll have to excuse me, I'm having a little bit of trouble with. There it goes, thank you. Yeah, we don't use these too often. So after the egg is released, the follicle does not disappear. It reforms into another cystic structure called a corpus luteum. The only job of the corpus luteum is to produce progesterone. Progesterone is a hormone that's made for about 14 days out of a normal cycle. It is a progestational hormone that works to mature the endometrium and prepare it for implantation of a fertilized egg. This process obviously occurs every month. And here you can see it in a schematic. Here's the ovary. You can see the little cells that will become eggs. They do mature inside this follicle. The follicle is going to get larger each and every day as that egg matures. You can see little tiny cells within the follicle. These cells' job is to produce estrogen. And as that follicle becomes larger and larger, it produces more and more estrogen until it becomes mature, at which time the egg is mature. Within 24 hours, the egg is ruptured out of that follicle. That follicle heals itself, becomes a corpus luteum, starts producing progesterone, and does that for the remainder of the cycle. And here is kind of a graph of all the hormones working together. We talked about FSH coming from the pituitary. It's going to instigate the maturation of that little egg. It's also going to cause that follicle to grow. That follicle is going to make estrogen in ever-enlarging amounts. LH is then secreted. LH is called luteinizing hormone. Its job is to help that cyst rupture and release the egg. You can see that it spikes right before ovulation. After ovulation, now we see that corpus luteum is being developed, and here's the progesterone that comes from it. It gets very high in the post-ovulatory phase. and then slowly comes down as we go towards our menstrual cycle. And so obviously, once an egg is fertilized, it has to be picked up by the fallopian tube, goes through the fallopian tubes and implants. And then, of course, we're pregnant. But most women, each cycle is not a cycle of pregnancy. So at birth, every woman has a finite number of eggs. We can't even guesstimate how many. We presume between 300 and 600,000 by the time we go through puberty. Through the course of your reproductive life, a woman will ovulate anywhere from 1 to 2 eggs each month. And during that time, a few others that were in various stages of development will die off and get reabsorbed by the tissue. If an egg is not fertilized, then the endometrial lining inside the uterus is shed and the process starts all over again. So the lining of the uterus is known as the endometrial lining, and it sits inside the endometrial space inside the uterus. Estradiol is a growth hormone and causes this lining to grow. When progesterone is being produced, progesterone will stop the growth of this lining and stabilizing it, awaiting for a fertilized egg. Of course, if an egg is not fertilized in the cycle, the corpus luteum will degrade and stop forming progesterone. The endometrial lining will shed, and the cycle starts all over again. You can see that here. This is the menstrual phase where we're shedding the lining. With the development of that follicle in the egg and the production of estrogen, estrogen is going to cause this endometrial tissue to grow. Following ovulation, we start seeing progesterone. Progesterone is going to stabilize and mature this endometrial lining. And then once the body recognizes it's not pregnant, then this corpus luteum is going to degrade, causing the shedding of the lining with the loss of progesterone. And so here are some interesting pictures I thought I'd share with you. This is through a laparoscopic camera inside the human body. You can see this is an ovary. This is a fallopian tube. This is the ligament that holds the ovary in place. Here are some more laparoscopic pictures. This is the uterus. Here are the tubes. Here are the ovaries. You can barely see the fimbriated ends. This picture down here, you can see the fimbriated ends a little bit more clearly, and their association with the ovary. The ovary is attached to the uterus and the tubes through ligaments. This is a little bit more close-up picture of the uterus and the tubes. You don't have a good, clear picture of the ovaries here. And here's a schematic of this picture above it. So the ovaries, once the ovaries have ovulated all of the eggs that are in them, the ovaries will shut down and stop functioning. At this point, a woman is known to be in menopause. Follicle-stimulating hormone from the pituitary gland will gradually increase to signal the ovaries to bring an egg up to the surface for maturation, but when there's no eggs left, nothing happens. So FSH rises higher and higher. So the pituitary gland will continue to signal these ovaries to function for the remainder of a woman's life. Even though they won't function again, the FSH will rise. Without any eggs in the ovaries eventually shrink and stop producing estradiol. Considering progesterone is only made by the corpus luteum, progesterone is no longer produced after the last egg is released. And so we can take a look at that little schematic as well. Here we have the hypothalamus talking to the pituitary. The pituitary is sending out FSH. It's telling that ovary, hey, bring an egg up so that we can start the ovulation process. And so it stimulates the egg to produce the ovarian follicle with the egg in it. And all of these things are feedback mechanisms to tell the body what's going on, especially the pituitary. Estrogen levels are going to increase and increase and increase until such time as ovulation occurs. And then the corpus luteum is going to be produced. The corpus luteum is going to feed back at the pituitary and tell it, hey, pretty soon you've got to put out some more FSH so the process can start again. And degeneration absolutely tells the body to do that. You can see how interwoven all these hormones are and how kind of complicated this picture is when we look at it in detail, and this isn't even the complete detail yet. Here's another good picture I thought I'd share with you. This is a hysteroscopic picture of the inside of the uterus. And this is, they put a camera in through the vagina, which is here, through the endocervical canal here. And what they're showing you a picture of is this space from here and above. So you see these two little tiny dots. Those are the openings of the fallopian tubes on either side. This is the fundus. This white stuff here is actually the endometrial lining. This is what lines the endometrial space and what we shed with our menstrual cycles every month. So what is perimenopause? Well, perimenopause is that time just prior to menopause, and it happens for a very length of time. It's a time in our ovaries when the ovaries still have some eggs left, and the body is attempting to bring them to the surface of the ovaries so they can mature and ovulate. During this time, women will have months where they'll have an egg ready to ovulate every cycle, and your cycles appear very normal. And now a woman will also have cycles where eggs do not fully mature, but of course they're released in what we call an immature state. Because the follicle surrounding the egg is immature, after rupturing this egg from the follicle, the corpus luteum following that is also immature. So that means neither the follicle nor the corpus luteum are going to be producing the maximum amount of estrogen and progesterone during the cycle. Now, obviously, with less of those hormones, women are going to feel side effects. Some of the side effects of progesterone include PMS, heavy bleeding, irregularly timed cycles, irritability, insomnia. And these are just a few of those side effects you can have with loss of progesterone and even loss of estrogen with these immature ovulations. And then, of course, there's times when the cycles may have no eggs ready, and that cycle can be skipped entirely. What sometimes also can happen is instead of skipping a cycle, women go into what we call dysfunctional bleeding. We don't have enough estrogen to build an endometrium, so a little bit is constantly shed. And of course, we don't have a progesterone to help stabilize it and keep it in place. So we have this kind of continuous spotting that goes on. And so this time span can be short. It can be as little as 3 years to as long as 15 years. Perimenopause actually begins at the age of 35. It will end for most women between the ages of 50 and 60. Smokers can expect that the process will begin and end 10 years sooner than their non-smoking counterparts. So changes that occur in perimenopause are numerous. We're only going to touch on a few of them, but especially those that have a lot to do with the symptoms that we see. Endometrial lining will slowly thin out through the course of perimenopause. A normal reproductive lining measures between 0.4 and 1.5 centimeters, depending on the time of the month. Our menopausal lining will be thinner than 0.3. During the time between the end between the age of 35 and menopause itself, we can see this under normal healthy conditions getting thinner and thinner and thinner over time. Now we're going to talk about what happens if it doesn't here in just a moment. The endocervical canal that formed fertile mucus in response to ovulation now decreases that production of mucus, and so we see less and less fertile mucus. Some women stop seeing it entirely before they ever go through menopause. The uterus overall will shrink. The vaginal vault will become atrophic. Atrophic is a big word that means less elastic, dry, thinner tissue, and much smaller. And we can start having pain with intercourse because of these changes. The vaginal atrophy and the loss of musculature from the perimenopausal through the menopausal time can cause pelvic organ prolapse, which is a relaxation into the vaginal vault of your pelvic organs, your uterus, bladder, and your rectum. So more changes that can occur with the loss of estradiol, we start seeing bone development changes and bone loss, which continues to the detriment of bone mineral density. We see hair loss, bowel and bladder control may decline, skin thickness declines, sphincter tension relaxes, causing regurgitation of stomach contents into the esophagus, and we get things like GERD. And so I thought I'd throw in a picture of the difference between well estrogenized vaginal tissue and low estrogenized or atrophic tissue. You can see we have a nice thick basal layer of cells. There's a very thick layer between the intermediary cells, and then the top layer of cells here is very thick and kind of fluffy. You can see the size of these cells is very large and thick. In a low estrogen state, the perimenopause, postmenopause state, you can see that we still have the basal layer, but these are contracted. All the cells in the middle are kind of squished and shorter, and the top layer of cells is very, very thin. There's only one layer, and they're kind of thin and small and shrunken. And here's a picture of the cervix. I thought I'd add that because some people have never seen their cervix. That's what it looks like in a speculum. And so we're going to talk about some of the physical symptoms of perimenopause. We certainly don't hold on to these just as a menopausal symptoms. We begin to feel these while we're still sometimes having menstrual cycles. And that is hot flashes, night sweats, anxiety attacks, irritability, weight gain, joint pain, fatigue, muscle wasting with weakness. And these symptoms can occur all the way through perimenopause and for a few years after menopause. And some women even notice that things are worsening instead of improving as time goes by. So signs, more commonly, we see changes in our cycle. The cycles become short or they become longer, they become heavier, or they can become lighter. We have cycles now with more PMS symptoms than we did previously. We can see more clots with our bleeding cycle. These changes can continue through the end of perimenopause or slowly decrease through perimenopause all the way up to menopause. Because we're all individuals, we all experience menopause differently. Now, obviously, everybody talks about the hot flashes and night sweats. This is a simple thermoregulatory system change caused by the loss or the drop in estradiol. The changes that are occurring in the hormones of the brain are caused by the changes in the estradiol, and these hormones that regulate thermodynamics slowly become dysregulated. So because they're irregularly modulated, women experience these hot flashes and night sweats. Now, not all women will experience these. Some women will begin them in perimenopause and see worsening after menopause. Some will see none at all. During perimenopause, as estradiol drops, other hormones are affected as well. Because all of the hormones in our body are kind of intertwined with one another, during this time, we see things like hypothyroidism starting, higher cortisol levels starting, changes in clotting factors, and developments of type 2 diabetes, because all of these are hormonally associated with one another. What can be done? Well, this is a varied topic. Some women have such minor symptoms, we obviously don't need to do anything. Others have very serious symptoms, and we'll try everything we can to help reliever of those symptoms. But in the end, treatment is individualized as the individual. So the big question a lot of women ask me is, what about hormone replacement therapy? You know, everybody got kind of the wrong idea after the Women's Health Study back in the 1999 through 2003 time span. And so there was a lot of questions that were being asked and a lot of incorrect information being handed out. So historically, between 1970s and about 2000, every physician under the sun gave out what they called hormone replacement therapy. Hormone replacement therapy at the time consisted of a 17-beta estradiol and an artificial progestogen called Provera. There's a huge difference between artificial progestogens, the chemical, and your naturally produced progesterone. Progesterone is a natural hormone. It's something your body makes once a month. Artificial progestogens are chemicals, and they made them specifically to be anywhere from 500 to almost 10,000 times more potent than your natural progesterone. And they're chemically made so they can bind in both estrogen, testosterone, and progesterone receptor sites. So once the Women's Health Initiative study was concluded, that study proved beyond a shadow of a doubt that artificial progestogens, these chemicals, actually were causing a breast cancer. And as a matter of fact, the Women's Health Initiative study stopped prematurely only 3 years into its study because there were so many breast cancers associated with the artificial progestogens. Now, they continued this study in the other two arms that were continuing on. One had plain estradiol, the other one, patients had no medication whatsoever, and they found out that breast cancers were actually being decreased in women on natural estradiol therapy, more so than they were in people with no medication. So what it proved was natural estradiols can certainly help protect women against breast cancer, but it does more than that. Natural estradiols can also help with osteoporosis and decrease the breakdown of bone, whereas artificial progestogens actually cause osteoporosis, depression, changes in the semicircular canal of the inner ear causing imbalance. So obviously there's some OBGYNs out there that continue to prescribe this particular types of therapy. We don't. Most physicians no longer recommend any type of hormone replacement therapy, even though there are a lot of people out there that would do very well with it. Other side effects of hormone replacement include such symptoms of heavy bleeding, subsequent anemia, pain with periods, blood clots, heart attacks, and strokes. So what's the best treatment? The best treatment is absolutely individualized. For all women, we recommend exercise daily. Eat a very balanced, healthy diet filled with whole grains, green vegetables, and 1 to 2 fruits a day, lean meats, and low-fat dairies. Staying in a normal BMI between 22 and 24 will also help keep symptoms to a minimum. Should symptoms start, the treatment would depend on what the symptoms are. At Veranova, we do recommend hormones for some women, but we only use bioidentical hormones. And when we use them, we want to mimic the natural cycle and support the post-ovulatory phase, just like we would as if you were in a regular menstrual cycle. Other treatments may be medications for problems brought on by loss of estradiol, such as thyroid disorders. Now, other women may use herbal remedies and get perfect control for their symptoms. And depending on the symptoms, some women may need other medications, such as antidepressants. There are now on the market some medications that target the neurotransmitters, kisspeptin, neurokinin B, and dynorphin, which are responsible for the temperature regulation we talked about earlier. And this medication will stop hot flashes and night sweats. It's brand new on the market. Not a lot is known about it, but it does work. There are some natural remedies that are formed from root vegetables that mimic estradiol and can control hot flashes and night sweats through that mimicry, but we don't know how much it affects growth of the endometrium over the long run. Now, when things are fine, in the beginning of perimenopause, there are few to no symptoms, so you won't notice anything. If a woman stays healthy throughout this time, few to no symptoms as she reaches, there are few to no symptoms as she reaches menopause. Research has shown us that the worst overall health a woman is in when she reaches perimenopause, the worse the symptoms are. Ergo, the healthier you are, the fewer symptoms there will be. Once menopause occurs, symptoms can continue for another 2 to 3 years, but will eventually stop even without treatments. Obviously, there's times when there's a serious situation. So when to call the doctor? For those women who are having worsening bleeding month after month, seeking professional health care is the only course of action. With loss of progesterone, estradiol can cause unfettered growth of the endometrial tissue, and endometrial cancer can ensue. This is a medical urgency requiring testing and treatment. And what are the signs and symptoms? Well, they're the same as for the first line: heavier bleeding month after month, or continuous bleeding between cycles during the perimenopausal years. And what we do to identify that is we'll do an endometrial biopsy to see if the endometrial tissue has turned into a cancer-type growth versus benign overgrowth. Either way, the cure for this, both overgrowth and endometrial cancer, is natural progesterone. Now, that heavy continued bleeding can also sometimes cause anemia. This too requires a visit to your physician for assessment and treatment. So I know that sounded kind of scary, but in all reality, most people get through it in a year or two and live a happy life thereon. So I'm opening things up for questions. Does anybody have any questions?
Feel free to put your questions in the chat box, or if it's hard to word them, I could unmute you if it's better for you to, if you'd rather ask a question. One question, Carolyn, I think sometimes comes up is the chance of becoming pregnant as a woman is approaching perimenopause. I think sometimes women worry about becoming pregnant when they're getting older. Do you want to address anything about that?
Sure. Obviously, if you are still ovulatory, the chances of getting pregnant during your perimenopausal years are just as good as when you were perimenopausal. So the same as in your reproductive years. Suffice it to say, though, this is a time where we have a decrease in the amount of eggs that are left. So obviously, there is a decrease in the opportunities to become pregnant. And pregnancy itself, has been bandied about as a bad word for women over the age of 35. We are not old age pregnancies. It's just a pregnancy in a later life. Studies have already proven beyond a shadow of a doubt that ladies under the age of 19 have a higher risk of developing a pregnancy with problematic things going on with it than women over the age of 35. So there's probably a lot less to fear. We do, though, have to recognize the fact that women have had these eggs since their development. And obviously, they have in the past can come in contact with things that cause toxicity to those eggs. Most of the time, what we find, though, is toxins that are ingested by the body or we breathe in or we come in contact with will kill off eggs before they will cause mutations of those eggs. So in all reality, because you have fewer eggs left, because some of them may show some genetic defects that are incompatible with life, it's really just the chances of becoming pregnant are considerably lower.
Do we have any more questions for Carolyn? Okay, Carolyn, we had a comment here. I said the photos of the uterus, fallopian tubes, and ovaries fascinating. And here's, yeah, two questions. If natural hormones required, how does this affecting your charting's reliability?
Well, that's a good question because here, due to the fact that we utilize NAPRA technology is natural procreative therapy. What we do is we try to help out the cycle by assisting it to become more healthy. So in all actuality, what we see in our patients that we're assisting in this manner is charting becomes easier. When we use natural progesterones in the timing, and or natural estradiols in timing the way they're supposed to be, you actually have a better time and an easier time at charting, and charting becomes considerably clearer.
Okay, great. And then her second question, or I'm sorry, another question here. It says, I'm in the middle of having hormones tested from blood work. How accurate are blood tests? Fat soluble versus blood. So maybe you understand that better than I do, Carolyn, as far as.
Sure.
Yeah.
Sure. I think blood work right now is the most accurate form of testing for hormones, only because of the fact that that's what we have the most experience in. And the studies that I have read through, this experience dates back to the 1960s. And so we've been able to refine those studies to be able to accurately determine what exactly are we looking for. Let's take, for example, thyroid hormone. Thyroid hormone, like almost all the hormones, don't float through the system on their own. They have to have a chaperone protein take them through the bloodstream. And so anytime you see something called free, that is the ones that are non-bound to their binding receptor sites, which means they're excess. They're waiting to be able to hit a cell that requires their services. And so that means that you're usually doing pretty good if we have X amount of free or unbound hormone. Now, when it comes to fat-soluble hormones, fat-soluble hormones are a difficult one. We've only just in the past 20 years been able to measure them, and determining what measurements are healthy versus unhealthy has been difficult. So not so long ago, everybody wanted to know, is my vitamin D in a good range or is it in a bad range? And so, they took a whole bunch of normals and they said, well, or not a bunch of normals, a bunch of people with levels at a certain level. And they said, well, these people seem pretty healthy. they're at about 30. So we'll make 30 kind of the norm. Well, you know that vitamin D is fat soluble, which means that particular vitamin is being stored in fat soluble tissue. So what's circulating around in the system, is that an accurate reading of where we need to be? And that's a question that hasn't yet been answered. Is the body so unique? And it is, I can guarantee you that when it's in need of some vitamin D, does it release what it has in stores first? Or does it take from excess or loss? That's a question that can't be answered. And so for right now, where we are in science is, we trust that what levels they're giving us, which right now is, I think, a 30 something for vitamin D, we trust that that's accurate and try to keep our vitamin D levels above that. We'll find out more in the next 10 to 20 years if that was really a good way to test fat soluble vitamins. I hope that answers your question.
Thank you for the question. Okay, any more questions? Okay, here's the next question. All the fluctuation of symptoms seems to make charting extremely challenging. Does taking your basal body temperature help clarify or make things more complicated?
That's an excellent question. And so I have to ask the question back. Are you somebody who has disturbed nights every night? Are you somebody who has chronic illnesses? Are you somebody who has a very time schedule? And so there's a lot of people out there who work swing shifts. They work days this week and evenings next week and nights the next week. When we change that dramatically, that quickly, temperature is a little less dependable. When we're up and down through the middle of the night, like we are when we're breastfeeding babies every 2 hours, temperature is a little less dependable. When we have chronic illnesses, temperature is a little less dependable. Now, under the normal course of action, if you're a healthy person and you have a pretty stable lifestyle, then certainly I think that's an added benefit. I think it can help you to identify things a little bit more clearly when it comes to, I'm assuming ovulation is what we're talking about here. And so, yes, having that basal body temperature can certainly add to your fund of knowledge. Watching your cervical mucus will help add to that fund of knowledge, even though we already know that as we go through perimenopause, it's going to decrease. So we have to pay very particular attention to that. And then paying attention to any other symptoms you might have had while you were in your regular reproductive years. Some people had pain when they ovulated on the right or the left. Paying attention to those symptoms helps. So I am of the opinion that more knowledge is always a better thing when you can depend on that knowledge. I hope that helps.
Thank you, and thank you for the question. Any more questions? Okay. We have, for detecting estrogen dominance, the level in the blood is more important to know, or can the estrogen in your tissues have a big effect, or we just don't know yet?
Well, once again, because blood levels are what we know the best, it's what we lean on for being able to identify problems. And so the first thing that I will do with any patient is determine how much estradiol is circulating in the bloodstream. And, you know, people have used that term estrogen dominance because they have low progesterones. My personal opinion is, let's find out the progesterone levels, because we won't have as much effect from the estrogen if we have a normal complement of progesterone. And so getting a normal complement of progesterone would be our goal in that situation. And once again, we have to know what it is circulating because we don't have a more accurate way of figuring it out. People have been doing saliva tests. They're now doing Dutch tests. We can do biopsies. These kind of things won't give us a stable piece of information that we can rely on. And so as difficult as it is to always have to rely on blood levels, that's what we know the most about. That's what we have the most information about. And that's what we rely on the most to help us to make our decisions, is getting blood levels of these hormones. And once again, we're not just looking at circulating, we're looking at those circulating that are freely circulating, because we have to assume that there is quite a bit that's bound to tissue. And of course, we cannot measure what's bound to tissue. We have to see signs and symptoms. We have to go by presumptions of how much is circulating in the bloodstream. Does that make sense, or is there another question? Oh, okay.
Great, thank you.
Yeah, and I'm sorry, it does sound horrible. And we were trying desperately to sound or help it make it sound not quite so horrible and a little bit more positive. But you know, that's what we're here for. We're here to take away the horror from that time and make it a little easier time for you.
Carolyn, even though you did say that it's very individual, do you have, in your experience, would you say maybe half the women have difficult symptoms, or a third of the women, or most women, or, like, what have you seen as far as the percent of women who have difficult symptoms in perimenopause?
Well, I'm kind of at a disadvantage here because I have a specialty in taking care of women's health. And so I unfortunately only see the ones that are having problems. If I had to do percentages.
That's true. That's true. People don't come to you if they're not having a problem.
That's exactly right. You got it. But we've been able to help every woman that has come to, mostly, I would say 99% of all the women that have come asking for perimenopausal help. We've been able to adequately help them through various means like we discussed on the slideshow. And so, there's nobody out there that can present me with a problem that's too much that I can't try.
Great, thank you. Okay. Well, I want to make sure everyone knows that if you have any further questions, feel free to send them into the office. That we are happy to make sure that we can pass those questions on to Carolyn, and that we will make sure that she's available. One thing I'd really like to ask also, if you could put in the chat box before you leave, if there are other topics that you would like to see in webinars like this, if you feel like this kind of format is helpful to you, what other topics would be helpful to you? Because Veranova Health does want to be helpful to our patients, and we would like to do what we can. I also wanted to mention one of the things, or a couple of things, I think a number of our patients found out as they were addressing issues with pregnancy, that our pelvic floor physical therapist was able to do a lot of things for the complications of pregnancy, whether it was, that shooting pain down the back of your leg, or backache, or, incontinence related to pregnancy, that Dr. Eberhardt, our pelvic floor physical therapist, had some great helps. And so I went to mention that she also can help women with some of the issues that Carolyn would have mentioned here, some of the things that come up related to prolapse or the dryness, other things that might be issues for women in perimenopause, that our pelvic floor therapists may have some tips and suggestions to help women through that as well. Okay, so we had a couple of things here we'd like to talk about: hypothyroidism, more perimenopause, and NRFP methods. That's a great idea. Okay. All right. Thank you so much for your participation, everyone. And we look forward to more health education through Veranova Health.